Hello and welcome back. We are now in part 2 of chapter 17 on the endocrine system, specifically focusing on diabetes mellitus. We finished part 1 with the clinical manifestations of type 1 diabetes, the peeing a lot, being really thirsty, and this paradoxical loss of weight, and of course urine containing glucose and blood with too much sugar in it. Now let's talk about a couple of acute complications of type 1 diabetes mellitus. The two that we're going to talk about are diabetic ketoacidosis and hypoglycemia, which again sounds contradictory, and I'll just clarify it right now. Hypoglycemia results in type 1 diabetes as a result of the treatment for type 1 diabetes. But let's take a look at diabetic ketoacidosis first. And the reason I'm doing it in this order, which is different from what our textbook does, is because sometimes the first thing we see, the first sign that we have that somebody has type 1 diabetes is that they present with this crisis, diabetic ketoacidosis. And so we're going to do that one first. So what we mean by this, DKA is caused by severe insulin deficiency. That is extraordinarily low levels of insulin, not just normal low levels of insulin. Let me clarify this. When somebody's pancreas is working, even when they are fasting, even if on a 5-day fast, I mean, I don't know why you would do that, but if you were going for an extended period of time without eating, the pancreas is still producing a small amount of insulin that is being released kind of in the background. It's the signal to the cells that there's glucose available and to bring it in. So that's happening all the time, again, even while fasting. This is levels of insulin lower than that. This is not producing that background amount. Let me clarify. If you've treated type 1 diabetics, you probably know they have different kinds of insulin that they take. This is the so-called long-acting insulin or the basal insulin. That's the kind of the background insulin, the stuff that is just, you need it even when you're not eating any food. And diabetic ketoacidosis occurs because they don't even have that. They don't have that background amount of insulin happening. Okay, so it leads to severe hyperglycemia. That's not a huge surprise because the cells don't know that there's glucose available, so they don't know to bring it in. And then remember we said that the lipolysis is inhibited by insulin. Insulin is a signal molecule, and we've mentioned before it's a signal that glucose is available, and we're going to look at this in sort of the evolutionary framework. When is glucose available? Well, it's available when there are fruits and rich vegetables available, which happens in the summertime, and so the spring, summer, fall. So the body is set up in a way that, when somebody is consuming that kind of food, we want the signal like, hold on to the fat stores. Winter's coming, so like, let's save that stuff for when we don't have all this glucose available. And so by having the glucose available, the insulin signaling that the glucose is there to bring it in, it also signals adipose cells, chill, hold on to your stores. Usually we see DKA in type 1 diabetics, but DKA can also occur in type 2 diabetics, but only in those type 2 diabetics that are not making insulin anymore. So the type 2 diabetics that have had type 2 for a while and it's been uncontrolled for a while, and their beta cells have been over-functioning for a long time and they get burned out. And that eventually leads to that insulin deficiency. And I'm going to make the note here, but I'll explain it later. DKA is not the same as nutritional ketosis. Just having ketones in the blood is not an emergency. So we'll talk about this some more. I just want to make that point now and repeatedly throughout this lecture. All right, so let's clarify it here. And again, I think the video is probably covering this. What might be behind the video screen of my face is DKA versus nutritional ketosis. What's the difference? If you need to see this whole thing, it's in the PowerPoint file. So what's the difference? Over on the left is DKA and over on the right is nutritional ketosis. And this infographic was produced by Allison Hershidi. She is a type 1 diabetic. She's an RN and a certified diabetes educator. My connection with her is she's a former anatomy and physiology student of mine. At the time that she and I overlapped in anatomy and physiology, we both believed the party line of the American Diabetes Association and said things like, oh, you know, complex carbohydrates are necessary and all of that stuff. And separately, we both came to this very clear understanding that no, complex carbohydrates are not the solution for type 1 diabetics. And following a diet that keeps somebody in nutritional ketosis is a really great strategy for type 1 diabetics. And so anyway, let's talk about the difference here. So diabetic ketoacidosis, as I've said, is not the same thing as nutritional ketosis, the same way that hyperglycemia is not the same as euglycemia. Just so having excessive amounts of glucose in the bloodstream is harmful. Having the normal amount of glucose is desirable. The same way, diabetic ketoacidosis is an emergency, but nutritional ketosis, just having the normal or a manageable amount of ketones in the bloodstream, is not an emergency. In fact, is beneficial to patients. And as I've said, insulin inhibits lipolysis. Now, having lower insulin levels, not absent insulin levels, just having lower insulin levels, like what you get if you lower the carbohydrate intake. And I'm going to put some numbers on this. I'm not going to test you on this, but just for those of you who will understand this better with numbers, the typical American diet, people are eating hundreds of grams of carbohydrates a day, hundreds of grams of carbohydrates a day. When somebody says they follow a low carbohydrate diet, they're limiting themselves to maybe 50 to 100 grams of carbohydrate a day. When somebody follows a ketogenic diet, they're limiting themselves to 20 grams of carbohydrates a day. So much smaller amounts of carbohydrates a day. That level of carbohydrate allows the pancreas to not release as much insulin. It's still doing the background insulin. It's still doing that, but not releasing huge amounts of insulin. That allows the adipose cells to release lipids. And I'll talk about what ketones are on the next slide. But I wanted to point out, often when you talk with type 2 diabetic patients, and I'll bring this up again later, they'll often talk about having been trying to lose weight for years, and they struggle and they struggle and they limit their calorie intake and nothing works. And largely you can trace it back to just having very elevated levels of insulin that's been stopping the lipolysis. So now we have the opposite situation. We have somebody not producing enough insulin and not producing enough insulin, like absent insulin. That's going to lead to uncontrolled lipolysis. And that's the problem. It's going to produce excessive amounts of ketones. Ketones are acidic. That means they release a hydrogen ion in solution. That's going to lower the pH of the blood. Now, the kidneys are going to try to help with this. They're going to try to pee out, some hydrogen ions, but it's too fast. The kidneys can't keep up. And that resulting acid-base imbalance, that's called ketoacidosis. It's a severe form of metabolic acidosis. It's more than the kidneys can keep up with. And in fact, sometimes the respiratory system tries to compensate with something known as Kussmaul breathing, these very deep respirations. I'm going to play a clip of a video, I hope, for you. This is a kid that's come into the hospital and without the advertising. That's not
All right, this little guy actually presents here. He's a known insulin-dependent diabetic. and come in with a pH of like 6.9. He's actually got a little bit of.
I'm going to repeat that. This kid came in with a pH of 6.9. Normal is 7.35 to 7.45. And this kid is well below that because he has an inability to make insulin. He's had another challenge, as we'll see. I'm going to point it out now. He has a raging infection. He's got an abscess. And that's enough for a type 1 diabetic to trigger this stressor. This stressor is enough to trigger this crisis. He didn't have enough insulin on board to compensate for this increase in stress. And so his blood glucose went through the roof, and the adipose cells are dumping enormous amounts of ketones into his bloodstream, and that's making him so acidic that his body's trying to compensate by blowing off the carbon dioxide and adjusting the pH that way. That's what all the deep breathing is about. I'm going to let this play for a few more seconds and then we'll go back.
Bit of a probably a dental abscess that's kind of kicked him off here, but his breathing is really what we kind of call Kuzma breathing. And when you
I missed it. Okay, I'm going to go back for a second. What I wanted to point out was the pH. Well, it's under 7, and normal is 7.35 is the lowest that you want to see. And then the other thing I wanted to point out, his potassium is just a hair high, but this can be higher. The hyperglycemia because of the absence of the insulin.
And when you smell his breath, it basically has a very sweet kind of a acetone ketone sort of odor to it.
So the breath smells like ketones. It smells like acetone, and I'll show you why. I'm gonna jump out of here, but you can watch this whole video at your leisure. The link to the video is right here. All right, so DKA, it's a dangerous state caused by lack of insulin. Nutritional ketosis is normal. Blood glucose levels in DKA are quite high. In case you notice, the kid's blood glucose was over 500. In nutritional ketosis, normal blood glucose. In fact, you can only get in nutritional ketosis with normal and moderate intake of carbohydrate, quite low intake of carbohydrate. Ketone ranges we'll get to shortly, and the pH. Okay, the symptoms of DKA include this fruity breath, it's smell of acetone, and Kussmaul breathing may occur. All right, some more. Don't be alarmed. I'm going to show you some molecules on the next page so that you know what we're talking about. All right, so there's some terms. Triglycerides, remember, these are fats. These are the 3 fatty acid tails. Looks like this. This is the glycerol part over on the left. Then we have these 3 fatty acid tails. It's carbons and hydrogens over here. Okay, what we call ketone bodies, or ketones or ketone bodies. Here are the 3 that you would find in a human body. In the blood, you would find mostly beta hydroxybutyrate. It's not super important that you know that. These are the waste ones. Acetone comes out in the breath, especially for somebody who's not adapted to using ketones for fuel. And acetoacetate, this is the one that comes out in the urine, that some people put dipsticks to check for the ketones. This is the one that's being checked for. A person that is adapted to using ketones is not blowing off the ketones in the breath or losing a bunch in the urine. They're still producing them, and you can find them in the blood. So again, what we mean by nutritional ketosis, this is desirable. The concentrations in the blood are usually around 1 millimolar, 2 millimolar. Ketoacidosis, this is a pathological state. It's the same molecules we're talking about ketones. They're these ketones, especially this one in the blood, but it's in concentrations that are so high that the kidneys can't keep up with getting rid of the hydrogen ions. And I say here higher than 3, it's double digits. It's 10 millimolar, it's 20 millimolar. It's high in ketoacidosis. All right, so ketones. This is the carbon double bonded to an oxygen. That's what you see here. As you metabolize triglycerides, you're going to produce ketone bodies, both, this one, the double bonded oxygen right there on these fatty acid tails, as well as you continue metabolizing these fatty acid tails, you produce more ketone bodies, and that's what's used as fuel, and it's not poison, at least not in normal concentrations. All right, causes of diabetic ketoacidosis. When does this happen? It can happen in somebody who has type 1 diabetes and doesn't know that they have type 1 diabetes. So they're consuming normal amount of food, but they don't have the capacity to make insulin anymore. Or it's a type 1 diabetic who has maybe skipped their insulin because they forgot, or because insulin is expensive and they start rationing. Some of the patients have started rationing their insulin. So they're not using as much insulin as they actually need because they can't afford it. Physiological stress can trigger this, like with the kid that we saw. He probably had a raging infection, which is enough of a stressor to trigger this in some type 1 diabetics. Or taking medications that antagonize insulin, like steroids, for example. Yeah, I guess I can mention this. So physiological stress, the connection here is the production of cortisol. And it can be also the production of epinephrine, can also trigger an increase in the blood glucose levels, and can antagonize insulin. Contradicts the effect of insulin. Here's the pathophysiology of DKA. So the starting problem is acute insulin deficiency, not just lower levels, but severely lower levels of insulin. And the 3 consequences, we've already seen them. Decreased glucose uptake by the cells, because the cells don't know that the glucose is there. The second one we saw was decreased potassium uptake by the cells. And the third one was the decreased inhibition of lipolysis. So let's do them one at a time. Decreased glucose uptake by cells leads to high blood glucose, not a huge surprise. And then it can be made worse by some kind of stressor, either an infection or some kind of psychological stress. What's important is we get an increased level of the stress hormones, which exacerbates the hyperglycemia. That is going to cause the peeing out of all the water, remember, osmotic diuresis, which results in hypovolemia and in extreme cases, hypotension. When somebody comes in with DKA, it is hugely important that the patient be rehydrated. They have to get more fluids on board. If you're ever advising a patient over the phone, my blood glucose is really high and I don't feel well, drink fluids. Parents tell get the kids to drink fluids on their way to the hospital if the kid is conscious. This is a huge problem. And then we'll come back to this over here, but I need to cover this middle one first. So decreased potassium uptake by the cells. As we've said, that's going to lead to hyperkalemia. So a lot of the potassium that's in the body is no longer tucked away inside the cells where it's supposed to be. Now it's out in the blood, it's in the extracellular fluid, so it can get peed out. And so the patient is losing electrolytes. The ones we concern ourselves with primarily are sodium and potassium, but the magnesium, other electrolytes are being lost. But this seems contradictory that they're hyperkalemic, then they're peeing out a bunch of the potassium. And then we start treating them because the acute insulin deficiency, we're going to treat that with insulin. Well, guess what? The potassium that they have left goes away. It goes inside the cells and goes away. It's still in the body, but it gets tucked away into the cells. Now they're hypokalemic. They have less potassium in the blood. And so we have to monitor potassium levels very closely in our patients that are being treated for DKA. And then over here, decreased inhibition of lipolysis. That's going to lead to uncontrolled lipolysis. The adipose cells are just dumping, cutting up the triglycerides and dumping the fatty acids in. We're making a bunch of ketones. The ketones, remember, are on the acidic side. And when we have uncontrolled amounts of them, the patients become acidotic. And that is where the name of this disorder comes from. Diabetic ketoacidosis. Ta-da! There is another condition that occurs that has some of the same characteristics, but is lacking the ketoacidosis part, because if there's any insulin present, that's going to keep this uncontrolled production of ketones in check. But we'll come back to that one. So DKA is primarily in type 1 diabetics. And then the other complication I promised you was hypoglycemia, that is having low blood glucose levels. And where this happens is it's a complication from the treatment of the type 1 diabetes. And what we mean by hypoglycemia is blood glucose levels less than 50s and 60s. I mean, somebody's blood glucose levels dips into the 60s. Nobody's going to get excited about that. It becomes a problem when the blood glucose level is well down, further down. This can lead to somebody falling into a coma. So it results from getting too much insulin for the body's current needs. That's what's key. The patient may have injected exactly the same amount of insulin that they always inject for this meal, and then something happens that they don't get to eat the meal. That can cause their blood glucose to go too low if they don't get the food intake that they're expecting, either because it didn't come, they got distracted, something happened, or they started vomiting, they couldn't keep the food down. Something happens where there's a mismatch with the amount of insulin that they took in and the amount of food that they were able to take in. All right, we usually see this in type 1 diabetics, but it can also occur in any diabetic patient that's taking insulin. Why it happens, as we've said, overdose of insulin for the amount of food that the person got. It can also happen with anti-hyperglycemic agents. There are some oral medications that can be taken that increase the amount of insulin put out by the pancreas. And it can happen as a result of those. It does not happen as a result of taking metformin. Metformin does not cause the pancreas to pump out more insulin. It makes the cells of the body more sensitive to the insulin that's present, but it doesn't typically cause this problem. Metformin I'm talking about. Okay, and as I've said, delayed or omitted meals after taking the insulin. That's the reason, of course, that we wait to give somebody their insulin, to make sure that their food is actually present in the room before we give them their insulin, even though there has to be a delay between when they give them the insulin and when they start eating. Increased exercise, especially without extra food. And this happens, I don't know if you've ever had a runner's high, just want to keep going with a group, they're all running, everybody wants to keep going, and the patient doesn't have extra glucose with them. This can happen under those circumstances. And then alcohol, and this one confuses everybody. So I'm going to bring back that diagram we've looked at before. So here's somebody planning their evening out. They are planning to have meals and a couple of drinks, and they inject the amount of insulin that they're expecting to need, and their blood glucose comes into the normal range. And then they're out dancing and they are having the drinks and their blood glucose level is falling, and the pancreas does what it's supposed to do, which is produce glucagon and releases glucagon. And the liver is supposed to break down the glycogen and release the glucose into the bloodstream. But the liver is busy with all this alcohol that it's trying to detoxify with alcohol dehydrogenase. And it cannot, at this moment, release some glucose for the patient. And that's how, kind of paradoxically, intake of alcohol can actually cause hypoglycemia. in diabetic patients who have taken some insulin. What this looks like, early manifestations. The sympathetic nervous system should be warning the patient that their blood glucose is low, so that it triggers the release of epinephrine. Patients become agitated, tachycardic. They have hard pounding heart, palpitations, they get sweaty, they feel uncomfortable. Now, this can happen actually when a patient is running very high in the hundreds of milligrams of glucose per deciliter of blood. When they start treating the diabetes, start bringing their blood glucose down, it doesn't even have to be in the normal range. It's still high, but it's lower than what the patient is accustomed to. They may get this feeling, and we just reassure them that this is normal. It will go away once the patient has gotten accustomed to these more controlled blood glucose levels. With this will normalize. Okay, so those are early manifestations. Late manifestations, this is due to decreased central nervous system function. The brain is largely dependent on glucose. And so this is where things get really dangerous, because the patients can become confused. That, these other symptoms are not that helpful. Headache, irritability, that can happen because of a lot of different things. But if a patient who's it does not suffer from dementia and suddenly they're very confused, this may be their blood glucose is too low. In extreme cases, this can lead to seizures and loss of consciousness. This patient needs glucose now. If they have an IV, they can get glucose through the IV. Most type 1 diabetics have glucagon as an injectable, as a medication. They need glucose on board. There are glucose gels that can be rubbed on their gums if they're unconscious and they can't swallow. Okay, they need to get their blood glucose back up. Curiously, patients who are accustomed to running with their blood glucose levels running lower, and they're accustomed to running on the ketones for fuel, they can tolerate lower glucose levels, blood glucose levels, because their neurons can run on some ketones. You still don't want them running really, really low all the time, but those patients, sometimes they have very low blood glucoses and they're still alert and oriented. All right, this big problem, hypoglycemia and awareness. This happens when a patient is repeatedly exposed to low glucose levels. Those normal warning signs aren't being perceived. Our job is to help patients figure out, why do they keep running low? I mean, clearly it's a mismatch with, the amount of insulin they're giving themselves and the fuel, the food that they're eating. And so we help them kind of line those things up a little bit better. And by avoiding the hypoglycemia for a while, we can sometimes restore partial awareness of the hypoglycemia. Okay, and that is the end of part 2. With part 3, we will go into type 2 diabetes. See you then.